Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of. Okay, so today we will be discussing the important disease that is immunoglobulin IgA nephropathy, IgA nephropathy. This disease is more common in Southeast Asia, including India. That's why we are discussing this IgA nephropathy. So the important thing, IgA nephropathy is also called as Berger nephropathy. This is important, and sometimes this term is used instead of IgA nephropathy. This is again the most common thing. This is most common chronic glomerular disease in children. Basically, this is not acute. This is most common chronic glomerular disease in children. As name is suggesting, it is characterized by Ig deposition in mesenchyme of glomeruli without systemic disease. Okay, the diagnosis is confirmed by renal biopsy. So this is basically introduction. It is diagnosed by renal biopsy. As name is suggesting, this is characterized by Ig deposition in the mesenchyme, and it is the most common chronic glomerular disease in children. Okay, so if confirmatory thing is a renal biopsy, what are the key histological finding? Just remember, just pay attention here. I will discuss later with help of diagrams. So on histology, focal and segmental mesenglial proliferation, basically extensive mesenglial proliferation seen. Increase mesenglial matrix, again it is proliferation and increased matrix in mesenglial stroma of kidney, epithelial cell crescent formation, and glomerulosclerosis. Mesenglial IgA deposition, because that's why it is called IgA nephropathy. So, what is the immunopathology behind it? IgA nephropathy is complex immune complex mediated disease triggered by excessively galactosylated IgA1 in serum. So, this is important. This is triggered by excessively galactosylated IgA1 in serum and focal and segmental mesenterial proliferation. Okay, when we see this histopathological slide of IgA nephropathy, first you are able to see extensive mesenglioproliferative glomerulonephritis. This is hallmark of this IgA nephropathy. If we see on light microscopy, these features will be seen of proliferation, and on electron microscopy, if we happen to see this is mesenchymal Ig deposition will be seen. So basically, in nutshell, Ig deposition with mesenchymal proliferation is the key for Ig nephropathy. Okay, this is immunofluorescence microscopy. Basically, this is immunofluorescence microscopy suggestive of IgA deposition in mesenchyme. So basically, what is this? This is pathognomic of this disease. Okay, so is there any genetic factors involved in this IgA nephropathy? Not as such, but some analysis is seen, or some genome-wide linkage analysis points to 6q22. Just remember, 6q gene, 6q chromosome location somehow linked to this IgA nephropathy. Okay, increased prevalence in Southeast Asia, including India. That's why we are discussing this disease as a separate entity. Okay, this is more common in male than female. This is male, more common in male than female. Okay, so clinical features, what happen in this disease? This is gross hematuria often follows an URTI infection. A child came to you, he has history of fever, cough, cold, and it gets subsided. After a few days, he or she presented with gross hematuria. That's how this disease is presenting. Microscopic hematuria and proteinuria are more common in Japan. Okay. Other manifestation, it can present at nephrotic and combined nephritic nephrotic syndrome type, but these are rare manifestation of IgA nephropathy. These are not common. Proteinuria is less than 1 gram per 24 hour in case of asymptomatic maturia. Serum C3 levels are normal. Okay. So infectious, post-infectious glomerulonephritis, that is PSGN, in PSGN C3 levels are decreased, but IgA nephropathy C3 levels are normal. And again, one important thing comes here: serum Ig level are elevated in 50% of pediatric cases only. Okay, uh, you are thinking this is IgA nephropathy. Serum IgA must be elevated in 100% of patient, but no, this is wrong. Serum IgA levels are elevated only in 50% of pediatric cases. Okay, so prognosis generally is good. Okay, prognosis generally good. Progressive disease occurs in 20 to 30% of children 50 to 20 years post onset. So basically it is a good prognosis in children, but yeah, in adults it might get progressive after 15 to 20 years. What are the poor prognostic indicator? You diagnosed a child with IgA nephropathy if he or she having persistent hypertension, diminished renal function, persistent or increasing proteinuria, then these are actually leading to poor prognosis or progressive disease. Okay, histological finding, if it is diffuse mesangial proliferation, extensive crescent glomerulosclerosis and fibrosis, also these are leading to this thing. So either clinical features or histological features, these are some suggestive features of that this disease will progress and may land up to end stage renal disease, but that is less likely. Okay, uh, we have diagnosed this IgA nephropathy on basis of renal biopsy. How we will manage this thing? Blood pressure control is the critical. Okay, so one drug which is wonderful in reducing proteinuria along with blood pressure control, these are ACE inhibitors or ARB. So the USP of ACE inhibitors or ARBs is they reduces proteinuria and they slow disease progression. So this is very important. One experimental thing is fish oil omega-3 fatty acid may help reduce progression in adults. Okay. Are there any other drugs used? Yes, immunosuppressive therapy in form of corticosteroid may added if proteinuria persists despite RAS blockade. Okay, so first thing you did RAS blockade, then if proteinuria persists, you add corticosteroids. So how this treatment algorithm works? Glucocorticoid can reduce proteinuria and improve renal function in patient with GFR more than 60. Okay. Now we'll see other treatment. Tonsillectomy. This is some weird, but yeah, tonsillectomy used in some countries because they thought of this disease might get precipitated by this recurrent UTI, just URTI, just remove tonsils, but this is not feasible therapy. Target release oral budesonide is the FDA approved for adults to reduce proteinuria. This statement is very important and this statement is being tested at various levels. So just remember this: targeted release oral budesonide is FDA approved for adults to reduce proteinuria. Is there any role of kidney transplantation in this? IgA nephropathy, yes, we can do kidney transplantation, but remember 15 to 30% of transplant patients having recurrent disease. So this is very much important. So this was it for this IgA nephropathy, and we will continue this amazing series or just remember, just revise this IgA nephropathy. We will meet in another lecture. Euconium Elias will discuss some another topic of this amazing series. Till then, do share, like, and